So block one of medical assessment, we're going to start with some acronyms. So we have BSI, which is body substance isolation. And remember, when we talk about body substance isolation, we're talking about vomit, urine, feces, as well as blood, anything that can come out of our patient. Then how do I protect myself from those things? We're going to use our PPEs, which is our personal protective equipment. And remember, that includes our gloves, gown, goggles, masks. That's what that includes, okay? Then we're going to walk through our acronym PINMAN. So we're looking at our personal safety. So remember, our personal safety comes first. Then my partner's safety, as well as we need to make sure we have our patient safe. And last would be our public safety, okay? Then E, we're going to talk about environmental hazards. So when we talk about environmental hazards, we are talking about any type of animals, power lines down. We're talking about any weather environmental hazards, so glass from traffic collisions, that's what we're talking about. Then we're talking about number of patients, that's your N. And as we know, we can have more than one patient. The M stands for mechanism of injury, so that's more used for trauma. Since we're doing medical right now, we're going to focus on our nature of illness, okay? So that would include like chest pain, shortness of breath, abdominal pain. Those are all your natures of illness. And then A is additional resources. So additional resources like additional ambulances, fire trucks, police, Medivac, those are all additional resources. And last, we have need for extrication or extraction, as well as a need for C-spine. So for instance, if I had a patient in medical that we found when we got on scene was found on the floor, I would find out how that patient got to the floor to find out if there's a need for C-spine or not. All right, so when we continue on, we just did our BSI PPE PINMAN. Now we're going to talk about our general impression. So remember, general impression can also be abbreviated as GI. But for general impression, remember, we are looking for specific things about my patient. Okay, so I'm looking for the age of my patient. Because remember, if you have an older patient, they might have a lot more kind of medical concerns that we need to explore versus someone that's a little bit younger. We're looking at the sex of my patient. So is my patient male or female? That would be important for like an abdominal pain call because I might have to ask about last menstrual cycle. Then we also have weight. When you guys get weight, you want to make sure to get that weight in kilograms because a lot of our medications are weight-based, so we want that weight in kilos. An easy way to kind of do that is if I say I have a patient who weighs 120 pounds, I would divide it by 2 approximately and get about 60 kilos, okay? So that's kind of easy way to do it. Then I'm going to look at the position found. So how is my patient found? Is my patient found supine, prone? Are they in a tripod position? Because that could tell us a lot about what's going on with your patient. And then you're also looking for any life threats because we know that life threats is something that could actually kill my patient sooner than later. So that would be an immediate load and go. So after general impression, we're going to go ahead and assess the alertness of our patient. We're going to use the acronym AFPU. So when we walk through AFPU, we're going to look to see, is my patient alert? Are they tracking me as I walk up to them? Or whenever I walk up to them, they're not tracking me, and I have to use my verbal stimuli to get their attention. If verbal doesn't work, then we're going to move on to painful. So what we do is we do a trap pinch. So we're going to find that trapezius muscle, put a little pressure on it to create a painful stimuli. And then the last one, if they don't respond to that, then they're unresponsive, okay? So what we need to remember is if they're alert, verbal, or painful, when I move to my ABCs, when I get there, I'm going to go ABCs. When I have a patient that's unresponsive, the first thing you should be checking is for pulse and breathing. So we're going to go CAB. So just think of it like I'm taking a cab, okay? So that's the way to kind of look at alert, verbal, painful, unresponsive. Now, after I do that, I need to introduce myself. I need to introduce myself to my patient. So I'm going to do an introduction, okay? And by introducing myself, I'm going to say, hi, my name is, you put your name there, you give your title. I'm an EMT student. How can we help you today? So remember, we want that introduction to be very professional. We don't want to be asking them, so what's your problem? That wouldn't work out very well. And that introduction is going to lead to our chief complaint. So our chief complaint is why the patient called 911, because that's pretty much what we're there to figure out, okay? So after we get our chief complaint of our patient, then we're going to walk through our PPTP. So the PPTP is basically trying to find out if my patient is alert and oriented. So the first thing we're going to do is we're going to get person. So what does that mean? I need to ask my patient, what is your name? It's really important that we make it very direct because we don't want yes or no answers. We want an actual answer and we want more detail. Okay, so what is your name? I would not ask my patient, to tell me, do you know your name? Because they're going to just tell me yes or no. Okay, I want to know what is your name. Then we have place. So for place, I could ask, where are we? I could ask them what city they're in. I could ask them a name of a place. Maybe we're at a store. We can ask them the name of the store. But again, we're going to ask, where are we? We're not going to say, do you know where you're at? Because they're going to tell me yes or no. Okay. Then we move on to time. So this one I want to ask maybe, what year is it? Okay. So I'm going to ask them what year it is. I might even ask them what day of the week it is. I may ask them what month we're in. So all of those would be fine for time. What year is it would not be a good one to ask, though, on January 1st, because a lot of people don't remember even what year it is. They don't understand that it's kind of changed already. But again, I want to ask them, do you know what year it is? Because they're going to then again respond yes or no. The last P could either be purpose or president. So you have two different questions that you could ask, okay? If you notice that your patient's not answering these questions correctly, I could ask them again, so what brings us out today? So I could see if the initial time I asked them matches the second time, okay? Now, if they're answering a lot of these questions correctly, then I would move on to a question like president, like who is the president? Because that's then a different question than what I've already asked them. I don't want to repeat myself if the patient appears to be able to answer the questions appropriately. So if they're able to answer all four of these correctly, we basically call that patient, so all four of these, we're going to call that patient alert and oriented times 4. Okay? Let's say they could only answer 3 of the 4. Then I would then say my patient's ANO times 3. If they could only answer 2, ANO 2, ANO 1, ANO 0, okay? But once I say ANO 3, ANO 2, ANO 1, ANO 0, I need to say they are alert and oriented to person, place, time, but maybe not purpose or president, okay? So I need to specify which ones they're ANO 2. If they're ANO 4, when we get to block 2, you guys would go OPQRST, okay? And if your patient is ANO 3 or less, okay, so if my patient is ANO 3 or less, then when we get to block 2, I will go over an acronym that is AEIOU TIPS. And we're going to ask that to a family member, bystander, or a patient's friend, because these are questions I'm going to ask a patient that's altered. Okay? All right, so after I find out if my patient is alert and oriented, then I'm going to move on to my ABC. So this is pretty much my primary assessment. So A stands for airway. So I'm trying to assess my patient. Is my airway open? Okay, if it's not open, we need to open it. You can open it with a head tilt chin lift or a jaw thrust. Remember, jaw thrusts are used for patients with possible spinal injuries. I'm going to check to see if it's clear. Okay, and if it's not clear, of course, then we're gonna suction. So that one falls a little bit lower, but need for suction. We're gonna make sure that we do that if our airway is not clear. And then I'm also gonna check to see if it's maintainable. Okay, is my airway maintainable? If not, then I probably need airway adjuncts. Okay, and remember our airway adjuncts are OPAs and MPAs. So, but if my patient's talking to me, they're able to answer questions, then we know their airway's open, clear, maintainable, and there's no need for suctioning or airway adjuncts, okay? Then we're gonna move on to breathing, okay? And in our breathing, we're gonna check our rate. Remember, the average adult respiratory rate is 12 to 20. We're gonna check for depth, okay? And remember, we can have shallow, we can have normal, and we could have deep, okay? So remember the analogy I give you guys is think of a swimming pool, right? So we have a shallow end, we have a deep end, and then most of the normal people hang out in the middle of the pool, right? Okay, then I also have ease. So rate, depth, ease. What I'm looking at for is my respirations, are they labored, okay? Are they labored or non-labored? Which one, okay? So I'm going to go ahead and take a look at that as well, okay? Then I also have to assess my lung sounds of my patient. What do they sound like, okay? Are we looking at wheezing, rhonchi? Am I looking at crackles? Are they clear? And remember, you need to assess them bilaterally, okay? Then we're also going to assess my SpO2, okay? Remember, that's going to be their sticker or the clip that you put on their finger. Average range, 94 to 100%. So that would be within normal limits. And then last, I'm going to evaluate all of this, and I'm going to see, is there a need for oxygen for this patient? Okay, and if there is a need for oxygen, I'm going to decide, do I use a nasal cannula, a non-rebreather mask, or a BBM? Once I've finished breathing, then I'm going to move on to circulation. Okay, with circulation, we're looking for the rate of the pulse. Remember, average adult pulse rate is going to be 60 to 100. We're going to look at rhythm. So is that rhythm, is it regular or is it irregular? Okay, and then we're going to look at quality. So is my pulse strong or is it weak? And then once I finish checking my pulse, then I'm going to move on to skin signs, okay? So when my skin signs, I want to know if what is my color of my skin? What is my moisture? And what is my temperature? Okay, so I'm looking at color, moisture, temperature. I'm also assessing a cap refill. Remember, if that cap refill is greater than 2 seconds, we call that delayed. If it's less than 2 seconds, we call that immediate. And then, of course, we also want to assess for hemorrhaging. Okay, but remember, we're not going to do what we do in trauma. We're not going to cut and expose. We're just going to assess for hemorrhaging to see if we have it. Now, once we've done our ABCs, I like to think of the next step as D for decision. I got to make a decision to transport, okay? So this is pretty much your decision. So my first transport. So my two options are, I'm either going to load and go, or I'm going to stay and assess. Now, how do we know what we're going to do for this patient? Well, the way I know if I'm going to load and go or stay and assess is if my patient has ALOC, which is altered level of consciousness. So remember, we did our PPTP. If my patient is ANO3 or less, then we know they were altered, so that would be a load and go. Then we would also look to see, do I have compromised ABCs? And if I do have compromised ABCs, again, I'd go back, I look at my airway. Did I do anything here? Did I do any interventions here? Did I have to do any interventions here? Is there something that's not within the norm that I'm a little concerned about? Then that would be considered a load and go patient. And the last one would be uncontrolled hemorrhage. So when I looked at my life threats from the beginning, okay, Or I looked at assessing my hemorrhage here. If I noticed that I had hemorrhage, then I would go ahead and decide I need a load and go and transport this patient.
Come in. Y'all are hiding.
All right, so we're going to start out with our BSI PPE PinMan. So I'm going to say body sepsis isolation, personal protective equipment. So I have my gloves on. If I need a mask, if I need any eye protection, I have all that available. Then I'm going to walk through my PinMan. So personal, partner, patient, public safety. So my scene is safe. Environmental hazards. I don't see any environmental hazards on my scene. Number of patients looks like I have 1. If there is a mechanism of injury or nature of illness, so we don't know that right now. Do I need additional resources? I don't think so yet. And then need for extrication, extraction, or C-spine, which doesn't look like it. So then I'm going to get my general impression. So I'm going to take a look at my patient, okay? So I'm looking for age, weight, sex, position found, and life threats. So I have a male patient. We'll say our patient is in his 40s. We find out that this patient is weighing approximately, we'll say that he weighs about 80 kilograms. And the position he's found looks like tripod. He's holding his chest, so I'm thinking something's going on with his chest. And then there are no apparent life threats that I can see right now. So as I approach my patient, I'm assessing my AFPU. He looks up at me when I came up, so I know he's alert on the AFPU scale, so I don't need to go to verbal, painful, or unresponsive, okay? So then I'm going to move on to my introduction. Hi, sir. My name is Instructor Signs. I'm an EMT student. What brings us out today?
I had chest pain.
You have chest pain? Okay, so I know it's chief complaint, so I'm going to ask him a couple more questions. Sir, I have a couple of questions I'm going to ask you. What is your name?
Gabriel.
Gabriel. Nice to meet you, Gabriel. Where are we right now?
Crafton Hills.
We're at Crafton Hills. Okay. And then what day of the week is it?
Saturday.
Okay. And then who is our current president?
Trump.
Okay. So he answered all those questions correctly, so I know he's a learner-oriented ×4. So I'm going to move on to my airway. He is talking to me, so I know his airway is open, clear, maintainable. There's no need for suction or airway adjuncts, again, because he's talking to me. So I'm going to move on to breathing. So, sir, I'm going to go ahead and I'm going to listen to your lung sounds. Is that okay?
Yes.
Yeah? Okay. So what I'm going to do is I'm going to go ahead and I'm going to pull my stethoscope out. Now, you guys would have a partner, so you could have your partner count respirations for you as you're listening to lung sounds, okay? So I'm going to go ahead and, sir, I'm going to go ahead and listen to those lung sounds on your back with how you're positioned, okay?
Okay.
So you guys are going to go ahead and put your stethoscope in your ears, and then I'm going to say, sir, go ahead and take a deep breath for me, and out. Awesome. Again, in and out. Okay, and then again, in and out. And then we're going to do one more time and then go under this arm, in and out. Okay, so I could tell that my lung sounds are clear. Okay, and as I count my respirations on my patient, we're going to go ahead and say that we have a respiratory rate of 28. He appears really shallow and labored. And then I'm going to go ahead and put on that SpO2 because I need to see what that reading looks like. Sir, are you okay if I place this on your finger?
Go for it.
Okay. So we're going to wait for a good waveform so we can get a correct SpO2 reading. And when we look at our SpO2 reading, it comes back at about 90% in room air. So to us, that's kind of concerning. We have an elevated respiratory rate. We also have lung sounds that are clear, which is good, but our SpO2 is kind of low too. So we're going to go ahead and we're going to provide oxygen for this patient. I'm going to go ahead and give him a non-rebreather mask, and I'm going to start him at 10 liters, and then we'll continue to assess him and see how he's doing to see if we see any improvement with that oxygen. So we're going to go ahead and just start it at 10 liters per minute, and then we'll reevaluate him in a little bit. If he's still kind of having a hard time breathing, then we can always bump it up a little bit. All right, so I'm going to go ahead and put this oxygen on you, okay? All right, so we have our oxygen on, then we're going to move on to circulation. So I'm going to check for his pulse rate, rhythm, quality. Are you okay if I borrow this hand really quick?
Go for it.
Okay, so I'm going to go ahead and I'm going to assess his pulse. And once I assess that pulse, it comes back at a pulse rate of about 110, strong and regular. I also need to assess his skin signs, so I'm looking at color, moisture, and temperature. So are you okay if I place the back of my hand on your forehead? Okay, so when I look at my patient, he looks a little pale, diaphoretic, and moist. I'm a little concerned about that. He also, he's warm to the touch, which is good. And then I'm also going to take a look at his cap refill. So can I borrow your hand really quick? Okay, so his cap refill is a little delayed. Again, we're probably not perfusing very well with what's going on with him. And then I'm going to assess for any uncontrolled hemorrhaging. I don't see any, so then I'm going to move on to my first transport decision. So because of the fact that we have some compromised ABCs, I know that he would be a load and go. He didn't have an altered level of consciousness, and we had no uncontrolled hemorrhage. So our big load and go criteria for this patient would be compromised ABCs.